carcinoma in situ. So this will be slightly different. I will not do your regular pathology stuff because you're going to have a pathology, what do you call, a seminar coming. Yeah, so we will cover all that in that particular lecture. So I will just talk to you about how do we clinically, deal with this situation of ductal carcinoma in situ, which is happening to be seen a lot in India also, because primarily ductal carcinoma in situ has come into the fore primarily because of these screening mechanisms. Can we just have everybody on mute, because I can hear a lot of noises. Children speaking. Okay. So let me just reduce this. Okay. So this all started in 1932 when Broders defined ductal carcinoma in situ as a condition in which malignant epithelial cells and progeny are found in or near positions occupied by their ancestors before the ancestors underwent malignant transformations, and they have not migrated beyond the basement membrane. So this is a beautiful description of ductal carcinoma in situ. And several years down the line also, we see that this is a spectrum that we see. It's not as if cancer cannot happen without going through that spectrum, but we are aware that there could be a spectrum of disease which migrates from an atypical ductal hyperplasia to ductal carcinoma in situ, when the disease is by and large confined to the duct, and then it invades the basement membrane to go into the stroma, and when it gets to be known as the invasive ductal carcinoma. So DCIS progresses to invasive disease in only 20 to 50% of cases. This is a very interesting observation, and that is what I want to bring to the fore. To think about DCIS as being a lesser evil. It doesn't seem to be, as we all know that DCIS is a lesser evil as compared to an invasive carcinoma. The whole outlook on DCIS is very different from what we would expect in an invasive carcinoma. We would expect 98 to 99% of patients to do well if they are suffering from pure DCIS, but the treatment, in fact, can be quite similar to what we do in invasive carcinoma. Sometimes it is probably worse than what we do in invasive carcinomas, because in a lot of invasive carcinomas, you do get away with breast conservation surgery, but in DCIS, there are some category of patients who would actually require a mastectomy, even if it is a lesser evil. So whether this DCIS is actually significant or not is the question that the whole world is busy answering. So what has been seen is that in more than 7 autopsy series of women, they found that the median prevalence of previously undetected DCIS was 8.9%. So possibly this was an innocuous lesion. It never went on to become a cancer. It was not of any clinical significance. So historically, DCIS has accounted for about 2 to 5% of breast cancers. But now we know that it accounts for about 20 to 25% of of all breast cancer cases that are picked up in the USA, predominantly because of the strong screening protocol that they follow. So there was a SEER review which showed that between 1975 to 2011, there has been an increase by leaps and bounds of in situ disease, which started off with 5.8 per 100,000 in 1975. Subsequently, the screening programs kicked in, and then they found that in 2011, it is as high as 35.5 per 100,000 women. In a study of women aged 50 to 69 years from 15 screening programs across the globe, 12 countries participated in it, and they found that between 2004 to 2008, the overall incidence of DCIS averaged about 16%. This is what you can see. There is the age less than 50. We know that the progression has been slow. We know there are not so many cancers for that matter. So DCIS is also low. But if you look at above the age of 50, you find that there is a huge rise in the incidence of DCIS. So this is the broadest classification scheme that I'm going to present to you. I will not go into the details of the pathology, but for us as surgeons, as clinicians, what we want to know is whether it's comedo or non-comedo. With comedo, obviously, it has connotations of a high-grade DCIS. Non-comedo could be cribriform, solid, micropapillary, and papillary, less innocuous lesions. And it is seen by Lee et al. That between 1980 to 2001, there has been a jump in the rates of non-comedo DCIs by 6.51 fold, whereas comedo DCIs increased by about 15.7 times. So if you talk about the risk factors, it is the same as for invasive cancers, but just to go over it quickly, hereditary factors, family history and a BRCA mutation operates in DCIS also. Reproductive and hormonal factors, the same. Nulliparity, long duration of breastfeeding. Nulliparity is a risk, it's a high risk, and a long duration of breastfeeding is protective. Breast density renders a 3 times risk. It is greater in premenopausal women, understandably so, because the density of the breast in premenopausal women is higher than that in postmenopausal women. A personal history of biopsy, there is a 2-fold increased risk of DCIs because it is possible that in that biopsy, you may have actually picked up the earlier spectrum of disease, which was possibly an ADH. Women with a BMI of more than 35, again, there is an increased risk of DCIs, especially in younger women, there is a decreased risk, but in older women, there is a higher risk. Alcohol and tobacco, again, there is an increased risk of in situ disease, the odds ratio being about 2.34 if it is more than about 2 drinks per day. And exercise and physical activity overall, it lowers the odds except in those with a positive family history. So if you look at the clinical presentation, DCIS accounts for, like I said, 20 to 25% of all newly diagnosed cancers. So pure DCIS in our country is not so common, but you do get to see a lot of DCIS in the West. And only of these 20 to 25%, only 13 to 14% are symptomatic because majority are screen detected. The symptomatic ones may be associated with an invasive component, and the most common presentation would be a breast mass. It could be Paget's disease because Paget's disease and in situ disease is clubbed together, and they both constitute stage 0. It could present as a nipple discharge, a sanguineous discharge, or it could be just a serous discharge. And there could be breast asymmetry because DCIs is known to involve a large part of the breast in some cases, and there you could come up with breast asymmetry. So I come to the imaging modalities now because this becomes very important. The important thing is how do you diagnose DCIS? So as we realize, as time has gone on, we know that screen film mammogram has been replaced by digital mammogram, and the detection rate of DCIS is higher with digital mammogram in 3 studies which compared it to screen film mammogram. And then we have had an increased use of MRI also. See, the MRI uptake has increased from 22.8% in 2005 to 52.9% in 2008, and I'm sure it is higher than that today. So the sensitivity of mammogram in detecting DCI is about 56 to 95%. It is a very good tool, the mammogram, for detecting DCIs, particularly if it is associated with calcifications. So the DCIs lesions, which are mammographically occult, if you're not able to pick up anything, there is a lump, but you're not able to pick up anything on mammogram, it is likely that it is a low-grade DCIS. It is the high-grade DCIS which is likely to be more mammographically apparent. And like I said, the most common mammographic findings are microcalcifications, although it may present as a mass or an area of architectural distortion. Like I said, 90% of DCIS are associated with calcification, and 80% manifest as calcification alone, and there may be no other mammographic finding. But what kind of calcifications is very important to understand. When you're doing a digital mammogram, there is the possibility of zooming in on images, but that is not a good alternative to geometrically magnified images. So you should try and get magnification images rather than try to zoom a normal mammogram. So calcifications in DCIS can be found in proximity to benign calcification. So when you say benign calcification, these are punctate calcifications. You could have, if it is less than 0.5 millimeter, it is in a group. There are 5 or more calcifications, they're grouped together. That is usually innocuous. And when you have macro calcifications, you have these big calcifications, that is not a harbinger of DCIS. They are benign. But those calcifications which are in the line of the ducts in a linear pattern. It is linear and it is branching along the duct, or it could be segmental. Again, the duct and its branches. So that gives a very segmental view. That has the highest risk of malignancy. And then you could have calcifications with necrosis in it. So like I said, highest DCIS related microcalcification could be fine linear. It could be fine linear branching. It could be fine pleomorphic. When we say pleomorphic, you do see these calcifications, all kinds of shapes and sizes, but they're really small, but the shapes are very pleomorphic. That happens in about 29%. You could have amorphous calcifications also in about 21%, and coarse heterogeneous calcifications in about 13%. So fine linear branching, it could be irregular, they're very thin, and they could be discontinuous also. But in an area, in a particular area, confined to a particular area, that should give rise to the suspicion of DCIS. So this is what I mean by fine linear branching calcifications. You can see that it seems to be oriented. This is a magnified view, of course, and you can see that they're very pleomorphic and in line with the ducts. So when associated, what is it that we are looking at when we find that there is no parenchymal lesion? There is then the chances that it is going to be pure DCIS is about 65%. DCIS with focal invasion is about 32%. So that itself is about 96 to 97% of your cases. Invasive carcinoma presenting without a parenchymal lesion is unusual. So it happens only in 4% of cases. However, when DCIS presents as a parenchymal lesion with or without calcification, it can have appearances of an invasive cancer. So invasive cancer would present as a circumscribed mass. It could be a focal asymmetry, or there could be an area of architectural distortion. So DCIS can also present in that manner. So there was this DMIST study, MIST trial, which is the Digital Mammographic Imaging Screening Trial. And this was in 2005, and it proved that a digital mammogram was equivalent to a film screen mammogram. So digital mammogram is better than the film screen mammogram in some ways because higher detection rate of calcifications. It may represent an overdiagnosis. Then there is digital breast tomosynthesis. When it is combined with digital mammogram, it does increase the sensitivity for both invasive as well as in situ cancers, although its value is smaller for DCIS. So digital breast tomosynthesis can reduce false positive callback because it is slice by slice, you're able to see tissue, and you do get rid of the overlapping tissue syndrome, wherein a lot of glandular tissue, when it collects together on a single film mammogram, may give the impression of an area of architectural distortion. So these are the various presentations of DCIS. You can see that that's the linear branching pattern. That's a very pleomorphic segmental pattern. That when you're seeing that it is starts off with the duct, it's a very inverted triangle kind of a picture. Then this is a focal. This is a lesion which you're seeing. DCIS can present like that, or it could present with an intracystic. If there is a cyst, there is a solid area. It could be an intracystic papillary carcinoma, which is also DCIS. So ultrasound is the other imaging investigation that you would fall back on. So we want to know whether ultrasound is as good for DCIS. So in the Akron 6666 trial, 2,600 women, high-risk women, were screened with mammogram and ultrasound. The mammographic sensitivity in this case was 50%, but when it was combined with ultrasound, it was found to be 77.5%. Ultrasound alone in the case of DCIS may not be beneficial because it can just give you some non-specific and subtle findings and you would not know what to make of it. But if there is a mass, of course, an ultrasound can show up a hypoechoic lesion, which is irregular. It can show an oval mass with non-circumscribed margins, but there may be no posterior acoustic change, but there could be hypovascularity in close to 70% of patients. But now with the kind of ultrasound machines that we're using with high frequency transducers and excellent spatial resolution and contrast, Lots of times it is possible to pick up microcalcifications also. Now, if you were to ask me about 10 years ago, if somebody were to say, MRI, is it a good tool for DCIS? The prompt answer would be no. MRI is a poor tool for DCIS, but things have changed since, and MRI is now known to be a very good imaging tool for DCIS. Three reasons, which again, technology has been a big factor in this. Earlier, it was temporal resolution. With the MRI, has shifted from high temporal resolution to high spatial resolution, and it can reveal specific morphological features which are suspicious for DCIS. And now with experience, there is a learning curve to every technology, and with increased use of MRI as a screening tool in high-risk patients, where you're more likely to pick up DCIS, it allows better comparisons with the conventional mammogram. An improved understanding of features of non-mass-like malignant lesions distinct from benign background enhancement patterns has also it has improved. So this is the learning curve, because otherwise the benign enhancement can confuse you with what you're seeing with a regular non-mass-like enhancement and give rise to upstaging of disease. So MRI had higher sensitivity than mammogram in detecting DCIS. This must come as a surprise to you, but that is the fact. This is a study which was done by Kuhl et al. In more than 7,000 patients, in which they found of the 7,000 patients, they found that 193 DCIS were picked up. About 56% were diagnosed by mammogram, 92% by MRI. And of the 89 cases of high-grade DCIS, 43 were missed by mammograms. About almost 50% were missed by mammogram, but it was detected by MRI. So MRI is an excellent tool for diagnosis, especially in cases of high-grade DCIS. It gives you a better assessment of multicentricity. This is something that you cannot underestimate at any point of time, because that is going to tell you what to do with this patient, especially in the case of multicentricity, and better estimation of size. It may be helpful in preoperative evaluation. However, what has been seen is, despite the preoperative evaluation, the COMES trial showed that there was no reduction in re-excision rate. But that is also, like, I always think that, all the frozen section is something that people don't conform to, and they say it is not possible to pick up DCIS on frozen. But in our institution, we have had pure DCIs, not as many as we have had invasive ductal carcinomas, but we have been served very well by frozen section, and our re-excision rate, meaning calling a patient back after surgery for a re-excision, is 0. So I think frozen has helped us in a lot of ways. But there is a flip side to every technology, and that is the case with MRI also. So MRI definitely will pick up more than what you actually went in for. It has resulted in additional biopsy in 38% of patients with DCIS, yet the rate at which these biopsies yielded a cancer diagnosis was not different from those who did not have an MRI. So MRI does tend to overestimate size, because the non-mass-like enhancement area can actually be bigger than the actual size of the DCIS. So about 44% overestimated it by 1 centimeter. So MRI does result in an increased rate of mastectomy, and we are looking at our patients, because we tend to do quite a few MRIs in our patients, especially in those patients who are desirous of breast conservation surgery, and we have actually turned the decision in favor of a mastectomy based on the MRI results. So in those who underwent BCS, this is something that we know, and that is why a lot of people do not like to do MRI. That is because perioperative MRI has not been shown to be associated with a lower local recurrence rate or a contralateral recurrence. But I can assure you, in a large percent, it's not a very large percent, but in about 10% of patients, we have picked up contralateral disease in a patient who presents with a primary disease on one side. So what is the morphological appearance that you would see on MRI? The most common is a non-mass-like enhancement, 60 to 80% of times non-mass-like enhancement. And that is where the trouble is also, because non-mass-like enhancement could be confused with benign background enhancement. In the experienced hand, There is a non-mass-like enhancement, which is more associated with ductal carcinoma in situ as well as invasive carcinoma. So if you see a non-mass-like enhancement, which is nodular, that is probably a non-mass-like enhancement of significance. Others are an enhancing mass, which happen in about 14 to 41%, or a focal area of enhancement, which happen in 1 to 12%. Like I said, the pattern of NMLE is very important. Clumped, heterogeneous are the ones that should be looked at very carefully. Clustered ring enhancement, homogeneous, and stippled. And the distribution of the NMLE is also important. A segmental one, again, is very often associated with, most often associated with DCIS. Then linear, focal is very, very uncommon. Regional and diffuse type of distribution should always raise the suspicion of DCIS. When we say a focal area of enhancement, it is usually very small, less than 5 millimeter. This is the least common morphology, and this is the one which troubles you the most, because if it is present, you have to go back, localize it, try and find it on the ultrasound if you can. If not, do a stereotactic localization, and this has to come out because the likelihood of it being a high-grade DCIS is close to 63%. So this is what it will look like. This is non-mass-like, and a very ductal kind of distribution. As you can see, there is an enhancement along the ducts, and that is what you would see on an MRI in a linear, in a segmental pattern of distribution. So now I will come to the evolution of the management of DCIS. Like I said, it is a lesser evil, but till very recently, I would say till about 20 years ago, the only treatment for DCIS was also a mastectomy. In fact, we had been doing mastectomies for till recently. In fact, extensive DCIS was an indication for mastectomy, but that is not true anymore. And along with the various NACBP trials, which showed that 04, which showed that the mastectomy was similar to breast conservation surgery, it has been extrapolated to DCIS also. So we know in NACBP B17, BCS joined MRM as the standard of care in the management of early breast cancer. And when you say breast conservation, now you're saying breast conservation in DCIS, so what is the role of RT? So that is the area of where there are a lot of questions keep getting asked. But as of today, there is no subset in which you would not add radiation in DCIS also. So there were 4 major prospective randomized controlled trials to assess the role of radiation after BCS. So the NACBP B17 was the one which showed that decrease in ipsilateral breast tumor recurrence from 16.4 to 7% at 5 years by addition of radiation, and 32 to 16% at 12 years. So this is a very, very significant change, 50% decrease in recurrence. The EORTC 10853 at 10 years again showed similar results. The Swedish DCIS trial, a Swedish trial, 22 to 7% at 5 years. So similar results. We came to this conclusion, yes, after BCS, radiation has to be added to reduce the risk of ipsilateral breast cancer recurrence. So just a word before I go into details of the radiation trials is whether we should be addressing the axilla at all in DCIS. I can assure you there was a time when we were doing axillary dissection in DCIS also, especially in patients who were undergoing mastectomies, even otherwise, because that was the only thing that was there to offer. SLNB had not come in at that time. I'm talking to you about 15 years ago. We used to do axillary dissection even in DCIs and been guilty of patients landing up with lymphedema for something as less or as innocuous as DCIs as compared to an invasive carcinoma. But now with sentinel node biopsy, it is important to ask this question as to whether we should be doing sentinel lymph node biopsy at all in a patient of DCIS. It is not routinely recommended, but in our situation, I would still go ahead and do an sentinel lymph node biopsy in an intermediate grade or a high grade DCIS, whether it is breast conservation or mastectomy. But if you're doing a mastectomy, you must certainly do SLNB, because going back into the axilla after a mastectomy, which says there was an invasive focus, is not an easy thing. In fact, it's not possible. Exceptions are also cases where examination, suppose you see on clinical examination that there is a biggish lump, and that is the usual case in our country. You will find palpable DCIS. If you have a palpable DCIS, I would not do SLNB. I would still do sentinel lymph node biopsy if there is a palpable area of DCIS, because the chances of finding an invasive carcinoma on final pathology is very high. So we'll go back to the randomized control trial. So these 4 randomized control trials were put together. A meta-analysis came about in 2007, and it again said the same thing, reduces the risk of both invasive and in situ recurrence by about 60%. And the EBCTG meta-analysis of 2010 again showed that there was a 15.2% absolute risk reduction of IBTR with adjuvant radiation. But there was no OS benefit or decrease in metastasis. At least this was the EBCT analysis of that of the 4 randomized control times of that times. But there is an EBCTG PCG analysis which does show benefit in overall survival also for those patients who are even 1 node positive. So that is how things have evolved over a period of time in of course invasive cancer, not for DCIS. So now we have to answer this question. Are we over-treating DCIS with RT? Is there a subset where we can do away with RT? Because when we're saying that DCIS is a lesser evil, we have to have the opportunity of de-escalating treatment also. So there are proponents of omission of radiation because they have shown that you have not been able to show us an overall survival benefit. So why should you do radiation? And you should be actually sparing the morbidity of radiation without sacrificing any meaningful clinical outcome, which is a great statement for those who propose to not do radiation after BCS in DCIS. So there were early retrospective studies. These were all in the 1970s when they showed that the lowest published, in 90s, and Legios et al. Showed that the local recurrence rates were really low. And then there was stringent criteria for excision were applied, low grade, size less than 25 millimeter, excision with 1 millimeter margins. This was all happening in those days. But then what was seen was there was a 12% IBTR at 5 years, which is acceptable, and 16% at 10 years with no breast cancer related deaths or systemic recurrences. So that is what is the aim. But I'm sure the stringent criteria did contribute to getting such good results. So there were prospective, that is when prospective trials were thought about, and we said, let's see whether there is a group where you can omit radiation. So in 1995, there was the Dana-Farber trial. It was a phase 2 trial. The low grade or intermediate grade DCIS of less than 2 centimeters with margins of 1 centimeter or negative re-excisions treated with BCS alone. And they found that the 5-year survival, 5-year local recurrence rate was 12%. Unfortunately, it closed prematurely in 2002. Similarly, there was another ECOG study. Again, in this study, tamoxifen was allowed, but this was not randomized, the tamoxifen bit. The 5-year IBTR in this was 6.1%. And the high-grade group, high-grade DCIS group, the rates were high, 15.3%. Again, another RTOG trial showed BCS versus BCS plus RT in low grade or intermediate grade DCIS with 3 millimeter margins, follow-up of about 6.4 years, closed prematurely again. But there were at local recurrence at 5 years was 0.4% for women treated with radiation and 3.2% in the observation group. So this was giving more food for thought. So people said there must be something that we should do, some independent predictor of local recurrence. That is when Silverstein and his colleagues embarked on this process with the help of the University of California. This is the California state, where they looked at an index which could help stratify DCIs based on independent predictors of local recurrence. This is the VNPI, you all would know it, the Van Nuys prognostic index. So the original model took into consideration the tumor size, the margin width, and the pathological classification, which took into account the nuclear grade and the presence or absence of comedonecrosis. So the goal was to provide, the important thing was we have to have a score which is reproducible. There has to be some standardization possible so that the treatment decision could be based on that, model. So a numerical score was assigned from 1 to 3, and the sum of the scores provided a VNPI score ranging from 3 to 9. So they applied this to 333 patients, and they found that there was no statistical difference in local recurrence rates of patients with whatever be the score, whether it was lower VNPI score, whether RT was used or not. So patients with higher VNPI score, 5, 6, or 7, a statistically significant 17% reduction in risk of local recurrence was seen when RT was used after excision. So now they're seeing a small trend that, higher VNPI score, you've seen that the risk of local recurrence is reducing. So for the highest VNPI score, statistically significant difference in local recurrence rates was seen in the two groups. However, overall local recurrence rates in all cases with high VNPI scores, meaning 8 or 9, were about more than 60% at 8 years. So when you look at a VNPI score, if you were to generate an 8 or 9, all the information that you got was, okay, this patient needs to have a mastectomy because they were going to have a high local recurrence risk in the coming years. So in 2003, but it was still not able to answer the main question that they wanted to answer, and that is, which is that group in where we can avoid radiation. So in 2003, it was modified to include age as an independent predictor of recurrence. But again, no statistical difference in local recurrence with those scores of 4 to 6 with or without RT. Intermediate scores, 7 to 9, there was a 12 to 15% reduction in IBTR, but IBTRs were close to 50% in those who had a score of 10 to 12, and their mastectomy was advised. So in 2009, there was an ECOG prospective trial. This is the E5194 trial. This is not a randomized trial. There were 665 patients, two cohorts. The cohort 1 had 500 plus patients, and cohort 2 had about 100 plus patients. So the first cohort, less than 2.5 centimeters of low-grade DCIS or intermediate-grade DCIS with an excision margin of 3 millimeters. The 12-year local recurrence rate was 14.4% and an invasive recurrence of 7.5%. So they had a low rate of 5-year local recurrence at 6.1%, and RT could be avoided. This was what was proposed. The second cohort was an even smaller size of tumor, less than 1 centimeter DCIS, high grade, but at 12 years, the local recurrence was 24.6% in the high grade group, and in the invasive recurrence was about 13.4%. But now to accept it is a little difficult, because they say, okay, we're not doing the full radiation. There is another fallback mechanism, and that is accelerated partial breast irradiation. In view of that, it has been difficult to get these into a recommendation. And you must also understand, in this trial, the interesting thing was the median size of tumor. So this is all screen detected. 6 millimeters in cohort 1 and 7 millimeter in cohort 2. So really small tumors. And here you would get good results irrespective of what you would do, whether you were to add radiation or not. So then Lee et al. Embarked on validating the VNPI in 2013. So there was a retrospective review of 294 patients with pure DCIS who underwent breast conservation surgery between 1990 and 2009. 57% of these patients had low risk scores, 40% had intermediate scores, and 3% had high risk scores. Overall, radiation in this study did not reduce risk for local recurrence. Recurrence rates were similar, whatever be the VNPI score. Interestingly, in 2008, NCCN low risk criteria was listed, and excision alone was an accepted treatment for DCIs. But now there are some other studies which are ongoing to answer this in low grade DCIs. I'll come to that subsequently. So USC applied this criteria, which is pure DCIs less than 2 centimeters, age more than 50 years, grade 1 or 2, margins more than 2 millimeters to 205 patients. And they treated them with excision alone. And that was a brilliant recurrence risk of 7.8% at 12 years. So in a very select case, we are actually getting that answer that possibly this could, these people could avoid radiation. So while radiation does reduce local recurrence from 50 to 3 to 4%, but then in this subset, possibly it was not required. So then various attempts are being made to, validate where we can, to apply an assay to understand who are those patients who may possibly not require radiation. There is this 12 gene assay. When it was applied to various groups of doctors, radiation oncologists, and surgical oncologists, the score did change the decision regarding radiation about 31.3%. But mind you, again, it was in low and intermediate grade DCIS. So we are really parking the high grade DCIS on one side, but we are looking closely at the low and intermediate grade DCIS to understand, can we de-escalate treatment in these subgroups? So the DCI score was associated with the risk of developing ipsilateral breast events, and the 10-year risk of developing IBE were 10.6 in low grade, 26.7 in intermediate, and 25.9 in high grade DCS. Pretty similar, intermediate and high grade, possibly intermediate. If you were to go back and look at those blocks, it is possible some of those intermediate grade DCI would actually qualify as high grade. And the risk for invasive breast cancer events was 3.7% in the low grade DCIS, which is an acceptable event percentage, and 12.3 in intermediate grade DCIS, and 19.2% in high grade DCIS. So invasive is what we're really worried about, and we know that when a DCIS recurs, 50% of times it will be invasive, especially if it was high grade DCIS. So then we are looking at forward looking. If you were to look into the futures, there are other biomarkers that we are looking at in DCIS. The conventional biomarkers that are associated with invasive breast cancer apply to DCIS also, and that is ER, PR, HER2/neu, and Ki67, and add a P16 and a P53 to it. The usual predictors of recurrence in DCIS continues to be the lesion size, the nuclear grade, architectural pattern, if it is what kind of pattern, was it a very widespread segmental distribution, margin status, and the presence of comedonecrosis. All these are predictors of recurrence. So biomarkers may also help in predicting treatment response and recurrence, and also to individualize treatment. And why not? If we are doing that in invasive cancers, we should be able to do it in DCIS also. So there is an expanded set of markers which have made a foray into DCIS. And I'll just read out the name. PR, of course, is PR and FOXA1, SIADH2, COX2, HER2, Ki67, and P16, and clinical pathological features like age, size, margin, palpability. All this was tested in the SWE-DCIS study, where to gain predictive information regarding RT benefit. When score is low, they found that there was no benefit from radiation. When it was high, the hazard ratio was significantly reduced to 0.24%. So that was the radiation bit. So we are looking at methods to de-escalate radiation treatment, but we do not have robust evidence as of now to do away with radiation in any subset, whether it is low grade or high grade DCIS. This is work in progress, and I will come to those trials which will give us an answer on this one. So when you talk of systemic treatment, so we have to talk about hormonal treatment, because we know that DCIS does not qualify for chemotherapy. So it was the NSABP B24 which answered this question. In 1,804 patients, tamoxifen was compared to placebo in women undergoing BCS followed by radiation. Fewer recurrences were seen at 5 years in patients treated with tamoxifen versus placebo. So a Cochrane review in 2012 showed similar results. It is beneficial in reducing recurrences in patients, definitely. So you would not give tamoxifen in a patient who's hormone receptor negative. There was a time when we did that, but now for all practical purposes, it is only hormone receptor positive patients of DCIS who will require tamoxifen. So when we are at tamoxifen, obviously the question will be asked whether we should be doing AIs instead of tamoxifen in postmenopausal women. So the NSABP B35 between 2003 and 2006 compared 5 years of aromatase inhibitors versus tamoxifen, and they found no difference. However, in a pre-planned analysis, they found that the young postmenopausal women showed some improvement in DFS, but nothing as far as overall survival was concerned. And the same happened with IBIS-2. They also showed no difference, and it is still being seen till 2016. There was no difference in the disease-free survival. So so that brings us to the role of neoadjuvant hormonal treatment. This is very interesting because we know about the role of neoadjuvant chemotherapy and neoadjuvant hormonal treatment in invasive carcinoma. But this is a study by Chen et al. Who studied the pathological and biological response of neoadjuvant endocrine therapy in patients with ER-positive DCIS. So 41 patients, small study, with screen-detected DCIS were randomized to receive 3 months of tamoxifen if premenopausal or letrozole if postmenopausal, followed by surgery. So significant pathological alterations were seen related to reduction in proliferation. So that is what was seen in that study. And this is another abstract that was presented in SABCS 2017 by Huang et al., where they looked at MRI detected volume changes in ER-positive DCIS patients in postmenopausal women after 6 months of neoadjuvant letrozole. So they found that there was a 33% reduction in DCIS volume measured by MRI after 3 months of letrozole therapy. And it did not increase at 6 months of treatment because that is when you would want to do surgery. So upstaging to invasive cancer did happen in 8% of the excision specimen, with no residual DCIs in 13% of specimens. So DCIs disappeared in 13%, which is also an area of study. The upstage rate is lower than expected because most studies, you would expect an upstaging of 15%. You go in thinking it is DCIs. When you excise it on final pathology, you will find that the rate of invasive carcinoma is 15% in that DCIs, while the absence of residual disease is not very different, which previously reported rate is 10%, and here they said it is about 13%. So when you talk of endocrine treatment, there are a lot of defaulters, especially when it comes to DCIS, primarily because it is a tablet that has to be taken every day. So the compliance issues are there. So alternative dosing approaches have been thought of, intermittent therapy with aromatase inhibitors and transdermal delivery through breast skin. The idea is to achieve the same therapeutic benefit, but to reduce the systemic side effects. So a gel formulation of the active tamoxifen metabolite, which is 4-hydroxy-tamoxifen, was tested against oral tamoxifen in a randomized controlled phase 2 trial. This happened in 27 women with DCIS, and the treatment was given for 6 to 10 weeks prior to the resection of DCIS. And the results suggest that topical 4-OHT reaches sufficient concentration in the breast to have a biological effect, but the plasma levels are lower than oral tamoxifen use. That's such a wonderful thing. You don't want it to be in the plasma because that is what is going to give rise to the side effects of oral tamoxifen, and your target site is getting sufficient concentrations. So transdermal delivery promises to, it obviously bypasses the hepatic metabolism with its resultant activation of the coagulation cascade. So obviously less systemic toxicity because the circulating levels are low. So this is a subject for a future trial, a phase 2 trial, which is ongoing, and they will recruit about 100 women across 6 sites in the United States. So coming to the HER2/neu gene, a lot of times, at least, you keep getting wiser as you keep reading about these new things. We would not do a HER2/neu in a DCIS. We still probably won't because these are all, like I said, work in progress, and the results will unfold in the years to come, and it is possible that HER2/neu will find significance. So we know what the HER2/neu gene is. It is a member of the EGFR receptor family. It has the strongest tyrosine kinase activity, and its activation leads to cell survival, tumorigenesis, cell proliferation, all those bits. And it is also associated with increased cell motility. And that is possibly one of the reasons it is at the cell membrane. It is actively involved in cell migration. And this migration is possibly what is going to decide the extent of the DCIS. D. Potter et al. Found that 67% of HER2 negative DCIS were usually less than a centimeter. And and 17% of HER2 positive, or I'm sorry, that is a mistake, it's more than 1 centimeter. So HER2 positivity was also associated with increased rates of recurrences. So this should really ring alarm bells, because we need to look at this if it is impacting the recurrence rate. So this phase 3 trial, this is the NSABP 43 trial, which is comparing ipsilateral breast cancer recurrences in HER2 positive DCIS treated with lumpectomy and RT plus 2 doses of trastuzumab to women, and that is one group, and the other is treated with lumpectomy and RT alone. So the primary goal is to evaluate whether addition of trastuzumab, those 2 doses, is going to reduce IVTR, and this is preoperative trastuzumab is known probably going to help increase the PCS rates also, as has been shown by a study in the MD Anderson group. What they observed was there was definitely antibody-dependent cell-mediated cytotoxicity that they could demonstrate. And preoperative lepatinib has also been tried as anti-HER2 therapy 2 to 6 weeks prior to surgery, but the results on what it did to cell proliferation are not available as yet. So there are various other anti-HER2 strategies. Preclinical data on short-course trastuzumab probably renders the HER2 cells more sensitive to radiation with no effect on normal cells. Again, a very good area for investigation. Like I said, I talked to you about the NACP B43 trial. So 2 doses of trastuzumab is what is given. And HER2 positive rate for pure DCIs among patients undergoing BCS is about 35%, significantly lower than was previously reported. So like I said, this is a pilot study from the MD Anderson. They enrolled 12 patients who received trastuzumab and 12 were untreated. These are non-randomized concurrent controls, but no significant differences in proliferative or apoptic changes, but they did observe ADCC in all patients. I've already mentioned this also about 1 gram of lepatinib. Now they're talking about vaccines against HER2 positive DCIS, and these vaccines are also being tested for invasive carcinoma. So these are very exciting things that we should be looking at. You should be aware of it. A HER2 peptide pulse dendritic cell vaccine to produce an immune response and sensitizes both CD4 as well as CD8 T cells. About 80% of participants delayed an increased immune response post-injection, irrespective of how it was delivered, because now you have a transdermal method of giving HER2 as trastuzumab as well. So rates of PCR in the 3 groups, 12 out of 42 evaluable patients had no residual DCIS in the surgical specimen, which is higher than the usually reported rate of about 10%, when no treatment is used between the core biopsy and the excision. But however, these are small numbers. And they will the other vaccine, which is again in invasive carcinoma, vaccination developed by Mittendorf et al. It is called the Nelipepimut S, an immunogenic peptide derived from the HER2 protein combined with GM-SF, which is also known as sagramostin, versus another group in which only GM-CSF was given. So these vaccines were given 2 weeks apart, and the primary objective is to quantitate CD8 plus T cell response in the 2 groups. The secondary objective obviously is to evaluate safety and toxicity also, and other immune endpoints to understand what it is doing, which is epitope spreading, histological parameters, including cell proliferation. Then there is a plasmid vaccine. A lot of interest being generated in this plasmid vaccine, which targets antigens from 3 proteins, which are known to be associated with giving rise to cancer, which is insulin-like growth factor, human HER2, and the IGF-1 receptor. All 3 are expressed in both pre-invasive and high-risk breast lesions and are associated with patients progressing to invasive breast cancers. So all these 3 proteins are immunogenic and elicit both humoral and cellular immunity. And WalkBack has been designed to have extended sequence of the immunizing antigens to elicit a type 1 immune response. And the type 1 immunity will result in recruitment of T cells secreting high levels of inflammatory cytokines, and this leads to destruction of the tumor cells. So this vaccine is being currently tested. It is in early phase trials of HER2 negative as well as HER2 positive breast cancer. So this is being used in invasive breast cancer as well. So now to come to the last bit of my talk, and that is the ongoing trials, which is de-escalation of treatment in DCIS. And the focus area here is the low-grade DCIS and the intermediate-grade DCIS. So there are three trials which are in progress. This is the COMET trial, which is again by the Dana-Farber Institute in the United States of America, started in 2017. The aim is to enroll 1,200 women more than 40 at the time of diagnosis with HR positive, hormone receptor positive, low grade or intermediate grade DCIS without necrosis. So they are randomized to receive GCC, which is the guideline concordant care, which includes wide excision with or without radiation plus endocrine therapy, or subjected to active surveillance, just observation, including a diagnostic mammogram every 6 months for 5 years plus endocrine therapy. So this is just endocrine therapy and observation, no surgery or radiation. So the primary outcome is to compare those proportion of patients with GCC who go on to develop ipsilateral invasive carcinoma after 2 years of follow-up. So this is a short follow-up study. So the hypothesis is that the low risk women over 40 with a low risk DCIS will not go on to develop invasive cancer at a rate that is unacceptable or jeopardizes survival. So that is the premise. So a number of biological assays are also planned, and this will further help us refine the selection of women who do not require loco-regional therapy. Same as the LORD and LORIS trials. The LORIS trial is being conducted by the University of Birmingham, and the LORD trial is by the EORTC. They're both looking at obviously low risk DCIS. They have longer follow-up intervals. They propose to measure ipsilateral invasive breast cancer over a 10-year period. The minimum age at entry is slightly higher as compared to the COMET trial, more than 45 years. So the DCIS must be asymptomatic. The symptomatic ones are excluded from the study. Screen detected, should be non-high grade, which essentially means low grade or intermediate grade, but they have not specified the ER status. Again, the hypothesis relates to non-inferiority of active surveillance versus standard therapy. If this equivalence is demonstrated, it will be a strong ground for not treating some DCIS patients with multimodality therapy. And around this trial, these two trials, also biomarker research is planned to make it more precise to present risk estimation parameters. So these are the three ongoing trials. In this form, it is very easy to see and understand what is being planned. While COMET wants to do a semi-annual 6-monthly mammogram, LORIS and LORD would do annual mammogram. And of course, all these three trials are going to look at invasive carcinoma at 2 years in the COMET and 10 years in LORIS and LORD. Thank you very much. So that is my lecture. I hope you have gained something out of this.
Thank you, ma'am. It was a wonderful presentation. There are some questions in the chat box.
Okay, let me look at the chat box. So Oncotype DX is used in DCIS treatment cost. Well, Oncotype DX, oh wait, let me start from the top. False positives are higher for MRI compared to mammogram. That is a problem. Yes, that is one of the problems. But like I said, the sensitivity is quite high. And like I always say, the technology has a learning curve. Non-mass-like enhancement can be confused with benign enhancement. And that is where the catch is. So you can actually be doing a lot more biopsies than you intend to. So that is a problem inherent with MRI, but with your learning curve, I think that reduces significantly, as we have seen in our practice. What margin for excision would you recommend for DCIS? So if you look at the invasive carcinoma, the recommended thing is ink on tumor. But in DCIS, you definitely want 2 millimeters. Is VNPI still being followed? So VNPI has not found its space. It is, like I said, it has evolved in some manner, in some ways, but it is not used to dictate treatment, not yet. We probably need better biomarkers to help us decide which patient will benefit from adjuvant treatment. Dr. Saurabh has written that they do use it to guide radiation treatment, but I'm not sure that we have evidence to show conclusively that the low risk DCIS who have undergone BCS could avoid radiation. But studies show that's right. So Dr. Pragna has also mentioned that unless it is extremely low risk, and I'm sure this question will be answered by these 3 studies which are ongoing, but till that time, I would suggest that radiation has to be given to those patients who undergo breast conservation for DCIS. So that question has been answered for VNPI. 4 to 6 lumpectomy alone, more than 6 add RT. Okay, so that's the answer to the question. 4 to 6 lumpectomy alone, more than 6 add RT. Okay, so that is what they follow in their institute. If that is an institutional protocol and it is serving you well, it is fine. But like I said, we do not have recommendations on it. Oncotype DX for DCIS treatment, no. There is a different, like I said, the 12 gene score, which tells you about whether to use radiation or not, but even that has not been very extensively used. But Oncotype DX is restricted only to invasive carcinoma, that to early breast cancers, specifically, I would say node negative, although they have some experience with node positive 1 to 3 lymph nodes. But if you just restrict it to early breast cancer, then the patient with ER/PR positive, HER2 negative, in a patient you want to decide whether you want to give a chemotherapy or not, then Oncotype DX may be one of the assays that you would want to fall back on. It's an expensive investigation, costs about 3 lakh rupees. How much common is it to get? Like I said, we don't, as a rule, do HER2. This is only food for thought for you, because in the future, I'm sure HER2 will have a role to play in DCIs also, because of the encouraging preliminary small number reports that we are getting. We do not get HER2 done. But if there is an invasive, a lot of times in DCIS, especially in our country, you would find areas of invasion. It could be 3 millimeters, 4 millimeters, 5 millimeters of invasive carcinoma. Then the invasive component should have a HER2 tested, because that can impact your treatment. Because over the size of 5 millimeters, you would want to give anti-HER2 therapy in an invasive carcinoma. So tamoxifen, yes, it is for systemic treatment, of course. So tamoxifen has twofold benefits. While tamoxifen has been tested in this as an adjuvant, we must also realize the importance of tamoxifen, which was demonstrated in the P1, NACBP P1 trial, which was the prevention trial, which showed that in proliferative lesions could be atypical ductal hyperplasia or DCIS or even sclerosing adenosis. There may be a case to put patients on tamoxifen for 5 years, because it is known to reduce the risk of invasive carcinomas by about 80%. But it is not widely used, but it is worth considering. In the US, it is quite used in these proliferative conditions. How will a gel substitute oral medications? Well, this is a question that I don't have an answer to. This is an intradermal gel that is supposed to release tamoxifen into the circulation, or to say that it just goes and sticks to the breast and does not pass the liver. So it has lesser systemic side effects, but I don't exactly know what kind of gel is being used. This is the OHT, which is the hydroxy tamoxifen, which is being substituted for the tamoxifen that we use orally. Because it has a propensity for breast tissue, that is why it possibly prevents the opposite breast cancer also, because it has a propensity for the breast tissue. So that is why it probably helps in contralateral breast cancer reduction as well. So we always look at this cohort of low-grade DCIS. So many times I think, oh God, this is just, a lot of times you find a DCIS in a major duct excision that you have done, which is just about 5 millimeters, 6 millimeters, and you wonder, oh, why should she go through radiation? But honestly, I don't have an answer to this question. And invariably, when we put the patient through the tumor board and we discuss it with the patient and say that we don't have the evidence, we will put them through radiation. But I'm sure, I am very optimistic, and I honestly believe that we are over treating low risk DCIs. In my practice, that is what I have seen, that I think low grade DCIs are possibly a cohort of patients which would never have gone on to become cancer at all. And we are probably treating something that we have just picked up incidentally. So there is a question, what is your take on a 55-year-old BRCA positive who was treated with wide excision alone for DCIS, followed by tamoxifen for 3 years, underwent a TAH BSO and is on tamoxifen currently, role of discontinuing it or AI? So you're saying it is DCIS. So DCIS, I don't think there is any role to give tamoxifen, or for that matter, any hormonal treatment for more than 5 years. She is a BRCA positive, but a BRCA positive, there is no contraindication to doing breast conservative surgery. So this BSO has been primarily done as protection for probably BRCA1 or BRCA2. I'm not sure what it is.
Ma'am, can I interrupt? It's BRCA1, ma'am.
Okay, BRCA1. So then there is, although what I think is BRCA1, even if it is BRCA1, after the age of 50, I don't know how much of risk reduction you manage to do. Because by the time you're 50, you've already lived 50% of your risk of developing breast cancer. But, if you were to take your lifetime as 80, there is still a 30% risk of developing breast cancer in the future. So I'm not sure. This is a controversial area, a huge area of debate as to whether you should be offering risk reduction surgeries in that group of patients. So this is something that is worth looking at, because in younger patients, yes, if there is a 37-year-old, I would possibly do a risk reduction. I would definitely recommend a risk reduction surgery at the age of 35, 37. And then probably 3 years down the line, I would even say a bilateral salpingo oophorectomy. But in older patients, I'm not sure how well it serves them by doing a prophylactic surgery. That's my thought on this. Is tumor size considered for de-escalation strategy? Yes, tumor size is considered. Like I showed you, less than 2.5 centimeters. Intermediate, see, I would not decide on the basis of whether it is intermediate, high grade or low grade on whether to do a breast conservation surgery or not. The extent of disease is what will decide whether it has to be conservative surgery or mastectomy. If it is a large area, you get these mammograms, I'm sure you've all seen them, with extensive microcalcifications in the breast. You are left with no option but to do a mastectomy and possibly offer her a reconstruction at the same time. But if it is a small tumor, 2 centimeters, 3 centimeters, or even 4 centimeters with oncoplasty, you're very well justified in going ahead with a breast conservative surgery. Provided you have all your imaging bits in order, you should know whether you're doing the right thing. And in this situation, you may be served well by doing an MRI also, because an MRI, one, can tell you the extent of DCIs, and it can also tell you, because once it is a 4 centimeter tumor, a palpable tumor, you must never discount an invasive component within it. Would you recommend MRI for all DCIs? I would, for DCIS, I would, because, I want to know what is the rest of primarily if I'm planning a conservation, like you've asked, whether for conservation and a DCIS, would I want to? Because if the breast is dense, so if you say an ACR A or a B, where, there is, the breast is dense and you are picking up this microcalcium, but I'm not able to really see the extent of disease, I would fall back on an MRI. And I can't tell you the number of times we have picked up additional lesions in the background of DCIS. So I would think MRI in a patient with DCIS, plan for conservation, MRI should be considered. Intermediate grade DCIS will not, like I said, does not change my plan. It is only the extent of disease that will change my plan. cost difference between a topical, I have absolutely no idea because this is not available for use. This is only in the trial setting. So we will know only when we get results from the trial, whether it is possible or not. And we'll know the price and all that. So that brings me to the end of all the questions. I hope I've answered them all. If there is anything else that you want to ask, please go ahead. You can unmute yourself and ask if you wish to. So I think we are done.
Since no one is asking the questions, I think the class is
Sorry?
Ma'am, I think no one is asking the questions right now.
Yeah, thank you. Thank you so much. Thank you for coming over. And it's a great experience. I always believe, this is food for thought. You've asked me questions. Obviously, we all learn together. So it's been a great experience. Thank you for being there. Thank you.
Thank you, ma'am.
Thank you for the opportunity.
Precious time.
Thank you.
Thank you.